Hello, everybody. Welcome to our event here. We're going to get started. Dr. John Davila, and I wanted to welcome everyone to this event that we're doing for the GCC, the FCS, and the Palmetto State, and also with some support from Matt McCoy as well. We're lucky enough to have today is Jennifer Dickinson. She is a certified professional coder. The whole point of this really is for Jen to go ahead and teach the changes and the coding. The other side of it is to actually have me come back in on the other side and discuss from a patient management standpoint and a doctor standpoint how all that works, the difference between what we're looking at as far as what the coder would think versus the way a doctor actually implements it. Because that's a great thing that Jen and I have as far as the ability to go ahead and give people both sets of information. So, Jennifer, you can hear me, is that correct?
Yes, sir, I got you.
Excellent. Let's go and get started.
Thank you guys so much for joining us today. Just as a heads up, my name is Jennifer Dickinson. I have been working with Dr. Davila here for, again, 10 plus years. We've been working together. It's been an amazing journey to go from a hospital biller where they were switching EMR systems. So I had the opportunity to kind of jump in and see behind the scenes of trying to refund an insurance company. And they're like, no, I don't want my money back. And you're like, no, seriously, you need to take it back and let me show you why. So you kind of like starting from that point and then slowly from there, going ahead and getting my credentialing and then jumping back into small practice and going, wow, okay, I really love this, but there still seemed to be a piece that was missing. And that had always been the connection between doctor documentation and then how we get to the CPT code. Because I can tell you from a hospital standpoint, when I see a code come back and I'm going through and reviewing files, we talk about the old E&M codes versus the new way we do it. The old way, back in the day, we would talk a lot about counting bullets. So, did I get all my review of systems? Did I get my history? Did I get my exam? And so it was a lot about like making sure we were checking boxes. And it wasn't as much about where we are now in 2021, which is more about what the patient actually presented with and what do we actually need to do with them. And so I know when I heard about the 2021 E&M changes, I was excited. Like I was all about it. I was like, man, this is going to make everybody's life so much easier that we can be able to go in and be able to actually document and code for what the patient needs. And it's no longer about fulfilling this requirement. Now, when we talk about like fulfilling a requirement, the requirements we're talking about are the 95 and 97 documentation guidelines. You guys, these are over 20 years old, archaic, it feels like, but they are very, very old, but they also had a lot of like vague terminology in them. So there was often times where you would hear contraindications of like stuff like one person with one payer would say one thing, but another payer would say another. So under this new 2021 umbrella, we're finding that there's a lot more clarification as to what actually do we need to have to support an E&M code. And so that's what we're going to be going through today, is actually going through and breaking down how do we choose our E&M code. There's two different ways that we can now choose our codes. We can now choose it versus time or MDM. So we're going to be going through those and breaking it down for you guys. Now, the big thing I want to make sure that we're clear on is that when we talk about scoring or choosing our E&M code, you still have to have things like a history and an exam. So even though that's no longer a component to how we choose our code, it is still something you have to have in your documentation for medical necessity. So one of the great things I heard about when I was listening to numerous people talk about these changes that are coming up is they refer to it as scoring. So I really like the terminology. So you no longer have to use history and exam to score the way you choose your E&M code. Doesn't mean it's not a component, doesn't mean you're not documenting it, but it's no longer a score that you have to calculate. Okay? So let's go ahead and dive into time. Makes it really easy. If it's a new patient, basically it goes up in 15-minute increments. So we can say 15, 30, 45, 60, and then established will go up in 10-minute increments. So one of the things I want to make sure you guys notice on this sheet is that we do not have a 99201 E&M code. There was a lot of redundancies in how the 99201 and the 99202 were both used. And so with that, they went ahead and got rid of the 99201, which just means that it gives you guys an opportunity to be able to make more money and use the 99202. So that is no longer in there. The other thing I want to point out that they did a little different here is they put us in time frames. So it's no longer just 15 minutes, okay? And then it goes to 30 minutes. There was a lot of confusion when it came to that. So they actually went ahead and built in this like 15 to 29 and 30 to 44. So all of these things are really, really positive in how you're able to choose your E&M code. So again, you can choose your E&M code now based on time or based on medical decision making. Now, time may not be the best way to manage it, so let's get into that a little together. So when we talk about a mechanic, if I take my car into the shop, they are set up where they are going to give you a quote based on the assumed time it takes to fix that part. So like if I need to get my timing belt replaced, they're going to say, hey, it takes 6 hours, and I have to pay for that whole 6 hours, okay? So that's the same kind of assumptions that we can make in the office. Now, the downside to that is that that may not be the most efficient way to run your practice. So you start to run into like, you kind of start hitting your head. So we say, okay, we have 10 new patients, all right, and if we use the time rule, then that means each new patient maybe takes us 30 minutes. We're coding it as a 99203. Well, that's 5 hours of your day that you're saying basically you spent doing just new patients. Well, that starts to kind of get into that idea of this like impossible day of how did you see 10 new patients plus adjust all these other patients plus do all this therapy. And so that's the reason that the time component is great, but it may not always be the most practical choice, okay? Now, time does include a lot of different tasks. Now, one of the big things I want to make sure you guys understand is that time includes doctor time. So face-to-face provider time. It does not include support staff time. So if your team members have to call and request records from an emergency room, that's not something that you can include in with this time. All right. Now, also, all of this time is things that you do in one calendar day. So if you're pushing your notes and you don't get them done until tomorrow morning, well, that doesn't count. So it's all stuff that falls within that same day. Tests offered and performed, such as Xrays, if you ordered the test and you performed it in your office, that would not be included in as the time component because that X-ray has its own TC and PC side of things. So it's not something that's included in with the time that you can bill for the exam. So let's just make sure we're clarifying that exam is exam, X-rays and tests ordered that you perform in your office, that is a completely separate item. Now, again, this is where we're talking about like when we're dealing with a high volume practice, documenting based on time, although it's really easy to audit. You know what I mean? Like if I'm going through and I'm auditing your file and you've documented this time, I can clearly go, oh yeah, okay, here he goes. We can be able to see it, history, exam, everything looks really good. I can see where you can spend 30 minutes with the patient. So that's great, but it's not the most ideal because if we talk about like the mechanic, you know, my mechanic may be able to get 4 timing belts done in one day, and all of a sudden, you know, that's a 24-hour day. That's a pretty good paycheck for him because he was able to do it. So that's where we talk about using the medical decision-making to choose your E&M code may be the best way for your practice.
Hey Jen, let me add something to that last slide for you. The other component to this is that from a review standpoint, what people have to remember, and Jen, you kind of hit on this, but I wanted to go ahead and make that point. When you look down, you say this is what is called an impossible day. So you have to understand if you're going to say you had 10 new patients that day and you billed them all 99203, and that took 30 minutes each, and you just said we documented 30 minutes for each one, you'd have to say, okay, of my 8 hours, that's 5 hours of my day. That's A. B, the next component is, okay, how many other time codes did you do that day? How many of them were you there for? How many sets of films? How much other time you had? You can end up in a situation where it's easily tracked if you're documenting based on time. for an insurance company to come back and say you had an impossible day, meaning you did too many services in one day, that caused us to go ahead and ask for records to see what's going on. Now, what we want to be able to, to look at here is to say, okay, we're doing all these things in a medical setting, which is really what we're trying to force ourselves into here when we're looking at what's on the screen. When we talk about these things, a lot of these things in here, counseling, ordering medications, we may not be referring all that much, all those different things, reviewing independent tests, all of the things that kind of like fall out of the way of what we're really doing. So, and when it comes to time, it may be easier to go ahead and talk about what Jen's talking about in a few seconds, but it's also something you got to also look at. Are we going to have things or times when we utilize time as a rationale for picking a code? Yes. Is that the best way to look at things when it comes down to someone who's trying to see a volume of patients? The answer is maybe not. So just, before you get there, just understand that may or may not be the case. The other thing also, because it has to be done the same calendar day, there's really no need for a timestamp. I don't have to say I started at 12:01 and finished at 12:44, because a lot of these things that you're looking at as far as total activities here may not be done in a single sitting. You may prepare to see the patient, come back in, obtain the history, review it, and then come back in. You go back to something else, come in, you do the exam, wait a few minutes, go handle something. Well, the patient brings their family in. Now you're dealing with the family. And so all those things are really just how much time did you spend? You just got to keep in mind that it's a total time answer. I did this many minutes, and just understand that, that may or may not be something you want to look at. If you're trying to see things at volume, you may want to go ahead and do these things as quickly as possible. That way we can get more of these done in a quicker amount of time as compared to just using time all by itself. So I just wanted to go ahead and make that point clear.
Absolutely. I think that's a good point to be able to make, because I think that's that whole, I imagine like in chess where they're hitting the clock. All right, we're going to stop, we're going to start, we're going to stop, we're going to start, because most practices don't work that way. They don't really have the time to sit there and just do 30 minutes with a patient, plus all the documentation, all the request records, everything. So that is an excellent point. So this is where I was just hitting on this a little bit separately. So services reported separately. So this is any specifically identifiable procedure or service, i.e. identified with a specific CPT code. In this case, let's talk X-rays. So like a 72-100, performed on the date of an E&M service may be reported separately. So if the service is something you are billing in your office and you report the exam 99203 and you report the 72-100, because it has the technical and professional component, it's not included in with your exam decision-making, your medical decision-making time. It's not included in with your time component, okay? Because it is a separate service that has its own time. It's already built into the CPT code itself. So that's where they call like double dipping. This is no different than like report of findings. I know this has been around for years, but we still have clients that sometimes ask us. So let's just make sure it's clear. If you do a report of findings on day 2, when you review the X-rays and the exam, you can't bill separately for that. It's already been included in with your exam and X-ray component. Where this does help you guys out is if you ordered an MRI on day 1, that can be counted as part of your E&M time component, because that is a test that you've ordered. So therefore we can actually do that, but it's not performed in your office. You're not billing the MRI. That's being billed outside of your practice. But when the MRI report comes back and you review and you analyze it, that's all part of that E&M service. So time or medical decision-making. Now, I feel like we've hit on this quite a bit, so just want to make sure that we recap a little bit. Busy practice, medical decision-making is typically the way to go. Now, time is great. It's easy to be able to support. It's right there. But I think really let's take a look at medical decision-making and see exactly what you need to be able to support your E&M codes based on these requirements. So if we look on the far left-hand column, we have our 99211, 99202, 212, 99203, 213, okay? The second column is talking about our level of medical decision-making. So we're going to really focus on this 99202 where it says straightforward. Now, if we come under these next 3 columns, this is where we need a combination of 2 of the 3. Okay, so we need 2 of the 3 columns here to be able to make sure we can support straightforward. So When we look at minimal, this is a self-limited or minor problem. A problem that runs a definite or prescribed course, is transient in nature, and is not likely to permanently alter the health status. So very, very clear on, patient comes in and they're having low back pain, self-limited or minor problem, okay? Easy enough. Now, this middle column is talking about complexity of data to be reviewed and or analyzed. So if you, in this case for a 99202, we don't have to request records from the emergency room. It's minimal or none. So again, with a problem like low back pain started 3 months ago, haven't seen anybody else for it, that's a self-limited or minor problem, no records are requested. Now the third column is talking about risk of complications or morbidity. So what's happening here is risk is the probability and or consequences of an event. The assessment of the level of risk is affected by the nature of the event under consideration. For example, a low probability of death may be high risk, whereas a high chance of a minor self-limited adverse effect of treatment may be low risk. Definitions of risk are based upon the usual behavior and thought processes of a physician or other qualified healthcare professional in the same specialty. So we're talking about if you adjust the patient, do you expect them to have any effect? Do you expect them to have any level of risk? The level of risk would be low because there's no probability of death based off that, okay? So that's what this third column is talking about, is that probability of death, that morbidity. That's 99202. All day and night, I feel like we can be able to support that, no problem.
Yeah. All right, so Jen, let me talk about this for a few seconds. When it comes down to, we're talking about a subluxation-based practice where we're dealing with diagnosis codes and treatments that are subluxation-based, that really don't get into a lot more of the condition side of thing, or not dealing with those other types of conditions. You're dealing with someone, you're managed subluxation. This is going to be the level of exam code you're going to deal with. We'll explain why in a few seconds when we get to 203. But there's been some conversation about 99202. I'm going to slide back here for a quick one here, about a self-limited problem or self-limited or minor problem that runs a definite prescribed course, transient in nature, not likely to permanently alter the health status. I've seen a couple other conversations with from other people teaching these courses saying that this, we would never use this because it's a medical necessity issue. That's just not true. Some of the things that that you got to look at is what the next definition is when we talk about acute uncomplicated illness or injury. There's a big difference here, especially when you get into some of the other CPC, Certified Professional Coder, conversations taking place when they start looking at codes. Start looking at definitions. These things here, when you're talking about self-limited or minor problem, someone that's not going to, is it going to leave someone, is the treatment and the problem going to leave someone with, and the condition, going to leave someone with a long-term disability or long-term impairment, those types of things. That's what it's really talking about. It's not saying that, it's a limited problem, transit's going to go away if you don't do anything. That is one component. There's more components to it than that. So if you're dealing with, simple situations, simple subluxation and simple diagnosis codes, you're going to be like more often than not using 99202 because of the actual complexity of the case. Now, one of the things that we're beginning to see here, and Jen kind of talked about, is the old way versus the new way as we start to look at this going forward. The old way, you got a lot of points for taking a really, really, really heavy duty history. And you talk about a million different things. And you got a lot of points in the past, in the 95 and 97 versions of the exam definitions. If you did a lot of testing on somebody, a physical exam, heart, this, strength, blah, blah, all these different things, a lot of points. We're beginning to see the change here compared to what people had in the past versus now. In the current situation that we're looking at, they're not looking at how complex how complex and how many things did you do from the history and exam component. Now that's all gone. What we're looking at here, as you can see from the first component alone, is two components. How complex is the patient's condition? And then how complex is the actual office visit itself. That's what the new version is compared to the old. The old is all the stuff that you did. Now, as you can see here, just 99202. Is it a complex situation for the patient? No. Is it a complex risk type situation if you're adjusting them and managing that condition for them? No. Is there a lot of complexity within the office visit as far as moving parts for looking at documentation and testing and getting other history? The answer is no. That's the reason why that's a straightforward situation. So that's a 99202 as we start to look forward into the 203 and 204s and 205s. How complex is the patient's condition? And then how complex is the office visit itself?
To add to that, Dr. Phillips, also the idea of goals of care. One of the things that we talk about a self-limited or minor problem is our goal isn't always, to get them out of pain. Obviously, that is our goal. But you're going to notice that in our documentation, a lot of times we're talking about ADLs and functional improvement. And so that's another way that we're going to be able to take that problem to be able to kind of expand on it. And so, hey, listen, this isn't just hey, we're getting them out of pain and moving on. But if we're able to talk about their long-term goal of functional improvement and that functional loss of being able to take care of their grandchildren or pet their dog or whatever that they're into, then that's when we're going to be able to really expand on that 99203. All right, so this is a little bit more difficult for sure. So we're talking about first column. This is a low level of medical decision making. However, I'm not sure if that completely classifies. And then we go to number and complexity of problems addressed. So if I start here with a low, it's 2 or more self-limited problems. This one's a good one. We're going to be able to use this one. When we get down to the one stable chronic illness or one acute uncomplicated illness, that's when things start to get a little fuzzy. So with acute uncomplicated illness or injury, it's recent or new short-term problems with low risk of morbidity, for which treatment is considered. There is little to no risk of mortality treatment, and full recovery without functional impairment is expected. A problem that is normally self-limited or minor, but is not resolving consistent with a definite and prescribed course is an acute uncomplicated illness. Honestly, sir, the difference is that the complexity that this may take longer. So the condition is going to take longer to resolve than what the 2 or more self-limited or minor problems would.
Yeah, Jen, let me jump in on this one also. Don't forget here we're talking about there's 2 components you need to think about when we're talking about acute uncomplicated illness or injury. One is we're seeing here when it talks about there's little to no risk of mortality with treatment, full recovery without functional impairment is expected. Totally understand. A problem that is normally self-limited or minor, but is not resolving consistent with a definite prescribed course of acute uncomplicated illness. Meaning, what you're looking for here from a documentation standpoint is, do you have complicating factors within the situation? That's the reason why if you say, well, you would never use 99202, no, 99202 as far as self-limited and minor problem, it's the same thing as an acute uncomplicated illness, except for the person has some level of complicating factor that's causing that problem to either not heal quickly or will remain with some level of long-term problem. So that's the reason why the commentary, you would never use 99202 because it's not necessary, it just isn't true as soon as you start looking at the other definitions. So remember, acute uncomplicated illness or injury is going to be proven when you get into your history and the patient has some type of complicating factor that's going to slow down. Some type of, let's say, joint degeneration or facet syndrome, something like that, is going to cause low back pain to not basically go away and leave the patient with, a reduced range of motion for a long period of time. That's what would be there. Okay. Now, the other thing I want to add also, Jen kind of slipped over this, but the idea of stable chronic illness, we're not going to use that as a problem, because a stable chronic illness is really meant for a physician to manage a patient's condition that is stable. Okay, so the doctor, physician is going to say, look at the patient and say, okay, you have diabetes, your condition is stable, you still have diabetes, you're taking your medication. Managing that patient with a stable chronic illness, that doesn't apply to us, because if the patient is stable, then there's no improvement to be had. So just understand, so a stable chronic illness is not something like we're dealing with someone who's got, a low back pain problem That's stable and chronic, that doesn't apply to this, because it doesn't apply to medical necessity, because there's no way to actually get the patient to improve. If they're stable, there's nowhere to go. So just understand, so we're going to strike through stable chronic illness. Yes, we'd have two or more self-limited problems if there's more than just one compared to 99202. And then if the patient has some type of complicating factor, then it goes from a 99202 to 99203.
When we talk about these complicating factors, I mean, I've reviewed enough records in my day. I can tell you that they cannot be assumed. Like, these complicating factors need to be made sure that they're documented. And that's where we talk about that history and that exam component. Just because it's not how we score our E&M doesn't mean you can't do a history and an exam. Those things are still critical for how you guys are documenting. So let's talk about this middle column. This is the amount and or complexity of data again. So in here, we're talking about limited. So category 1, tests and documents. Remember, 2 of the following. So we need to review of prior external notes from each unique source, review of the results of each unique test, or ordering of each unique test. Okay, so that's category 1. 2 of those. Now, external means external records. This is a communication and or test that are from an external physician. So if you have 2 specialties in your office, they're an external. Now, an external physician is a qualified healthcare professional. External physician or other qualified healthcare professional is an individual who is not in the same group practice or is in a different specialty or subspecialty. This is really great for those who, have hospital contacts. It's really easy to order those records. But for us small practices, oftentimes this is something that's handled by our team. So this is why, because it's not doctor time, this is why it's not able to use it as a medical decision, because then you can have your team be able to request records. So anytime you see records that a patient received services outside of the clinic, that should be a red flag. Have the patient fill out or request the records and you guys be able to order them. Category 2 is an assessment requiring an independent historian. Independent historian is an individual, parent, guardian, surrogate, spouse, witness, who provides history in addition to the history provided by the patient who is unable to provide a complete or reliable history. When we're looking at this black arrow is talking about we must meet the requirements of at least one of the 2 categories. So if I bring my 11-year-old into the office, you better believe he's not going to give you the whole story. So that's where I would become the independent historian, and I would be talking to you guys about the history. Okay? Or if you requested records and we had 2 of the following, then we could do category 1. So you're going to use only one of the categories, not both. Last but not least, let's talk risk of complications and or morbidity. So in this one, it's a low risk of morbidity from additional diagnostic testing and or treatment. So what we're talking about here is that the risk is low. That means after reviewing the data, history, exam, that you expect the patient to have a positive outcome from the adjustment and that the risk be low from treatment. Anything you want to add on that one, Dr. Davila? Are we good?
One of the things you got to remember here is when you're talking about documenting these things, what we're talking about, remember, you need 2 of the 3, right? So
Correct.
You don't even have, so if you've got your patient complaint, no problem at all, and let's say you use the idea of your child, you talk to the parent, you look at the case, it's a complicating factor, there's 2 self-limiting problems. I don't even have to document the fact that there's risk of morbidity at all, because I got 2 of the 3 done. So it could be the first one, second one, or first one, third one, or second one, third one. I could do a 99203. The patient comes in, I talk to the parent, I do my exam, I understand what the issue is, the patient has everything down. I could be in and out in 12 or 15 minutes as compared to a 30-minute minimum time for 99203. So that's how you start to go ahead and look at these bullet points in here, your data points, build your data points, get them done, get them out of the way, especially if you're going to review exterior notes. Now you can go ahead and have your staff, oh, you saw this pediatrician? No problem at all. Let me get those records. They're in. They come in, you read the pediatrician's records, you talk to the patient, you're done in just a few minutes as compared to having to spend a full 30 minutes as what we talked about compared to when using time. So 2 of the 3 and you're all set. You don't have to worry about, once you get the first one, second one, where the error is right now, you just bypass that one because they already have 2 of the 3, which is the minimum necessary for the code.
Yeah, absolutely. And I know I was talking to a clinic earlier today, and I was like, listen, you need to go ahead and get that request of records form. It almost needs to be sitting on your front desk, but you need to have them ready to go. Where it used to be, old way we talk about, used to be an afterthought to request records. Oftentimes, in most of the clinics we would see, that they would just not even request records, or they would do it and be like, I should take a look at those. Whereas now, it almost needs to be a forethought. This is really where we've been building to, is this idea of communication across the whole medical world. And so go ahead, and as you see patients come in, if they've stated they've seen somebody else for this condition, hand them that form. Get your staff to go ahead and send that request of records over. Take a look of it, because that's the big difference between 202, 203, and as you see here, it's also a role in 204 as well. All right, so with our 99204, we've now bumped up. Now we have the moderate level of medical decision making. So when we get into our number and complexity of problems addressed, so we need one or more chronic illness with exacerbation, progression, or side effects of treatment. So chronic illness with severe exacerbation, progression, or side effects of treatment. The severe exacerbation, progression of chronic illness or severe side effects may have significant risk to morbidity and may require hospital-level care. So I hope you guys are following here, but that's not really one that we're really see a whole lot.
Yeah, so we get through these, just get through these real quick. When you get to these points here, once again, we get the stable chronic illness. That's definitely not what we're talking about here. So, we just have to understand that all of these things that we're looking at here, once we start to look at this, we're looking at all the different levels. Acute illness with systemic symptoms, not going to be us. Acute diagnosed problems, all these things are basically just not going to be us at that point in time. So we look at undiagnosed new problem in different diagnosis, where we're talking about condition likely result in high risk of morbidity. Once again, that's not going to be us. And we get to the next one, and once again, acute systemic symptoms, all these different things. Talking about a single system, colitis, pneumonia, things like this. These type situations where there's, we're talking about subclinical minor. Definitely, it's going to be a reach. Those types of things. Then we get into acute complicated. This may be something that we're looking at a little bit more often, as far as the issues where we're talking about from a doctor standpoint, or we get to see a patient that may have had a head injury or brief loss of consciousness. That may be something we dealt with, in a whiplash, something like that. So if we're looking at where we're going to try and kind of focus to get to a 99204, that's probably the patient type that's going to get us to 99204, because remember, it's about not the complexity of the exam and the history, but the complexity of the patient's case.
Absolutely. And and monitoring those complicating factors and making sure that we've documented those, especially because that's going to come into play when we get into this complexity of data reviewed, as we start to really hit home with with being able to make sure that we're meeting those requirements and getting those requests of records. If they've had a head injury, did they go to the hospital? Did we do it? Did we order an MRI? All of part of that request of records. And then we also have the independent historian that would also fall into these categories as well. Now, when you get into social determinants, you're going to notice that over here under risk of complications and morbidity. So they start talking about moderate risk of morbidity from additional diagnostic testing and or treatment. So we're going to have prescription drug management, decision regarding minor surgery with identified patient or procedure risk factors, decision regarding elective minor surgery without identified patient or procedure risk factors, and diagnosis of treatment significantly limited by social determinants of health. So this is kind of newer terminology that we're seeing with the 2021 EM changes. Let's make sure we dive into what that actually means, because that's going to be a factor. So social determinants, basically it's the evidence clear social determinants of health, such as access to stable housing or gainful employment, may not be strictly medical, but they nevertheless will be a profound impact on the people's well-being. So unfortunately, our fee-for-service system inherently limits the doctor's-patient relationship to what can be accomplished inside the four walls of a clinician's office. So today's letter to state health officials highlights strategies by which states can promote a value-based system that fosters treatment of the whole person, and lowers healthcare costs. Patients are more than a bundle of medical diagnoses, and it's time our healthcare system treated them as such. So we're really starting to look at literacy problems here. We're looking at employment, unemployment, how is it affecting them, their occupational exposure risk, their housing, and then any kind of like if they're living alone, if there's cultural differences, if there's social exclusion, discrimination, all of those things would be considered social determinants. Still really cool to be able to see that this is starting to really develop and it starts to take a role into how we're actually able to care for the patients. Because there are limitations. If the patient can't drive to your office, that's a limitation. And so it's nice to be able to see that this is starting to become a factor and how we're able to choose our risk for a patient.
Before we get done with this, one more thing I wanted to go over. When we're talking about, once again, 2 of the 3, you can look at the middle section here. And when you look at the middle section, once again, you're in a situation where, it's going to be acute or complicated injury. We need 2 of the 3. We're probably not going to get to a moderate risk of morbidity where we're managing the patient for these types of problems. But we're looking at, once again, in the documentation side of things and the data points, we're going to look at it and say, okay, we need 2 of the 3. Can we get one of these, these tests from outside? Are we looking at that situation? We're dealing with interpretation of, independent testing. And then also management, discussing management with another physician. So all these things, you start to see now what we were talking about earlier. This whole issue of complication of risk is one component. I need 2 of the 3, and you can see now that all of a sudden we're moving up from a 202 to a 204. A 202 was so simple. I saw the patient, I talked to the patient. It was no big deal. It was pretty simple, and I did an exam, and there's a little risk. Now we're talking about a patient who may have had a concussion, for example, and they had a concussion, so they were in the hospital. I got those records. I saw the CT from before. Now I've got a 99204, not because of the complexity of just what I was doing as far as the exam, but because the office visit itself is so much more complex than it would have been for a 99202 and a 204 versus 202. And once again, 2 of the 3. Am I going to get sometimes where there's a moderate risk or, moderate risk of morbidity, or I'm going to deal with social determinants? I may deal with that. Like Jen said, there may be a situation where someone can't drive or they're illiterate, they don't understand what's going on, or maybe some other issues. But really that whole social determinant thing, for example, let's say someone, going back to diabetes again, we're looking at someone with diabetes, can they manage the diabetes correctly if they don't have the ability to get the right food? And they don't have the ability to go ahead and support themselves correctly, and they're eating junk food, it doesn't allow them to go ahead and manage diabetes correctly. That's one of the things that they're really looking at. Are we going to deal with someone getting to our office, or where they're working, things like that? Those type of situations maybe, but just understand, it's easier to go ahead and do column 1 and column 2, and basically manage the patient that way, closer to what we're trying to get accomplished. Can we get to the 3rd where the X is? Maybe not, probably not in most situations. But in 1 and 2, it's one of these situations that we start to see it's harder to reach to a 99204 as compared to when we're looking at data points in years past.
Oh yeah, harder, but not impossible now. We will not get to the number and complexity of problems addressed. So this is one or more chronic illness with severe exacerbation. We've talked about this one already. So we're not going to get that. One acute or chronic illness or injury that possesses a threat to life or bodily function. Again, we're not going to get it. You guys, we may get the data component of it because we can request records and we can try to work with other providers and be able to co-manage a case. But even the risk of morbidity, we're definitely not going to get there. So I feel like the 99205 is off limits. You guys, 202, 203, possibly 204, but yeah, 205, unless it's a time component. But yeah, it's going to really be stretching on being able to support that from a time standpoint.
Yeah, so you're definitely looking at time as one of the only ways you're going to get there, as far as one of the ways you only get to 99205. That's going to basically be, or 99215, that's going to be time. That's going to be a lot of time in the office to be able to get to that point. So what I want to do is I want to go over why this is an issue. And I don't think people realize why this is an issue as much as they think it is. And the reason why I say why, and I want to go back and give everyone a little history as to where this is going and why we're seeing this. And if you go back and if you've been in practice 8, 10, 15 years, you go back and you start to look at, as this changes and as it's changed, one of the things we've seen in the past was the whole $44,000 for meaningful use. They paid doctors and hospitals, everything else, $44,000 to go and implement these things. Well, what we're starting to really see, and I think you could actually, really see this in this whole MIPS, PQRS, all these different things that people were doing. This whole process here, this is money that the government basically invested. And when we look at the money invested, I think what we're looking at now is the government's trying to get their money back. What we're really, really trying to get accomplished here with this change from just what the patient's going through as far as one component and risk, I think that the other component that what people don't realize here is we go back and look at 99205, this whole entire middle section, right, where we know we have the 2X on the side, this whole entire middle section of data points that we need to get from the people, this really is forcing physicians to get into either playing nice with everyone else or having access to all these different things. Obviously it's easier for physician working within the hospital system to go ahead and download records. They go right into their system. They have multiple different physicians. They can go ahead and do all these different things and see it right away. But for us, this is going to force us to ask for this information as much as possible, as quickly as possible, in order to go ahead and get these data points. So in order to go ahead and move up from a 202 to a 203, and then 203 to 204, you're going to need to actually start asking for records in order to go ahead and check off these data points so you can move up in these codes. And if you look at the history, we start to see, that all this intercommunication is something that was basically, how can we say, was almost foreshadowed 10 years ago when the whole, meaningful use thing came out. This is something that the government said, we're going to want everyone to have, under HIPAA, we have the term, right? Health insurance portability, moving data from one person to the next to be able to make care more efficient. And that's really what we're seeing here. So, if you're going to do anything in the situation, obviously asking for records more often from all different physicians' offices, external to your office, going to be a major, major, major component to go forward. Jen, anything else you want to add to this?
No, I think the biggest thing that I can't stress enough, though, you guys, is that this is all about score, not so much about, the fact that you still have to do medical necessity, still have to do a history, still have to do an exam. It's just about scoring your E&M code and choosing the right one. Yes,
right. So you want to talk to us about how we can help you actually get through your day one faster so you're not actually spending 30 minutes doing day one. Let us know. We can actually help you with that also. So thanks for everyone being with us. We appreciate it. We'll talk to you soon. Take care, everyone. Have a great day.